we do fear pain. People, when they have
Yeah,
pain, they feel fear about their future, which then creates more pain, right? Because more
absolutely.
alarms are going off. So people get stuck in this cycle of pain and fear.
Absolutely.
Um,
And people say, well, how can it be my brain causing this pain?
mhm.
Because it's so severe.
Yes.
And the point is that all pain, like you said, is created by the brain. When you touch a hot stove, it's not your finger causing pain, it's actually the brain. And this is hard neuroscience. And it's
Yeah.
called predictive processing. Our brain creates what we see, what we hear, and what we feel. And so this 10 out of 10 pain, that's like a kidney stone or like labor, still can be caused by the brain in the absence of structural damage. And making that distinction is so vital because if you if you have back pain, stomach pain, pelvic pain, whatever, you're going to the doctor and they're saying, well, you need medication, you need injections, you may even need surgery. That's going down a path that assumes that it's a structural problem. And
Mm.
if you assume that, you can be wrong. In fact, you will be wrong most of the time, which is shocking.
Yes.
But you need a different path. You know, the treatment has to fit the condition.
And people's beliefs play a big role as well.
Yeah.
So I know in your book you talk about it's almost like the degree to which someone can say there's nothing physically wrong with me
Yeah.
is the degree to which their brain can start to begin to let go of pain through the processes that you teach.
Right. And we
Um,
look for the evidence. You know, it's not, we
yeah.
don't just see somebody and say, oh, your pain's coming from your brain by definitions. We don't know. We don't make that assumption. We want to
Mhm.
look for the evidence. You know, there was a
Yeah.
guy I met a while ago who had 25 years of back, leg, and then foot pain. 25 years. So it got so bad he couldn't sit because of the back and butt leg pain. And he couldn't stand because of the foot pain. So he had to quit work. His life was reduced to nothing, lying in a recliner, nothing, you know, depressed, suicidal. And he found out about this work. He looked at one of our podcasts and he said, that's interesting, but could that possibly apply to me? 25 years severe pain? And then one day he had a level like 5 pain. He was walked into a pharmacy to get a medication. And as he walked in, he saw a long line. And as soon as he saw the long line, he knew he was going to be standing in the long line. And as soon as he saw the line, within 3 seconds, his pain had jumped from a 5 to a 9.
Interesting.
And that was his moment. This is what we call the
Mhm.
click moment, where it just clicked for him. This is what it is. I get it now. And then once he had that click moment, once he understood it, he then started he had a physical therapist said, you need to walk. He said, well, I can't walk. It hurts too much. He said, I know, but you're not injuring yourself. You're not damaging yourself. It's your brain causing pain. Walk. So he walked a little bit and he kept telling himself, I'm safe. I'm okay. I'll be fine. But he knew it was true. I'll get better. And he walked more and he walked more and he walked more. Within 6 weeks, his pain was gone after 25 years. It's astounding that can
It
happen.
is. Uh, yeah, it is incredible. I think I know, people who have had headaches for 20 years.
Yeah.
Nothing showing up, but yet they feel like it's, a physical thing. They really feel
Of
like there's a
course.
physical,
Of course.
yeah, of
I
course
mean,
they do.
it's physical in the sense you feel it in your body and it's
Yeah.
real, you know, even when it's learned neural circuits in the brain, that's
Mhm.
physical, it's real. It's just not what we would call, in medical sense, pathological. There's no tumor that needs treating. There's no infection that needs treating.
Mm.
There's no inflammation that needs treating. It's neural circuits in the brain. And that's, that makes all the difference in the world.
Mhm. And I think, and do you ever run across this that people like it's almost becomes their identity? If
Mm,
they've lived with pain for a long time, it's like part of their identity. And it's almost like,
yeah.
well, what if this was just pain that was generated in my brain? Like, does that mean I've been crazy all these years?
Yeah, and then it's so easy to get offended, you know, and who does
Mhm.
you can't blame people for being offended or, you know,
Mhm.
if they think they're being dismissed or invalidated. Nobody wants that. Nobody deserves to be dismissed or invalidated. Certainly not women. Women have been dismissed and invalidated for centuries.
Mm-hmm.
So
Mm-hmm.
certainly we don't want to fall into that trap or that camp.
Mm-hmm.
Um, and we also don't, but we also want to say that there may be hope, because hope is a powerful thing. And when you lose hope, because you've tried so many different things for so long, it's devastating to,
Mm-hmm.
to live that way.
Howard, it doesn't seem like there's one name on this kind of pain. I've heard,
Mm.
like, in the John Sarno book,
Yeah,
he
yeah,
called it PMS. I noticed you were calling it mind body pain. Other people call it neuroplastic pain.
yeah.
Has the community, settled on a name for this type of pain?
I think we're close. We're calling it neuroplastic pain,
Okay,
or
that's what I've been
neuroplastic
doing most of the time.
symptoms and neuroplastic conditions. I have a new book coming out, and the book is filled with the word neuroplastic, because neuroplastic is neuro, the brain, and
Yeah,
plastic means plasticity. It can change.
yeah,
And that's the hopeful message of understanding that the brain can learn pain, and it can unlearn pain. It can learn
yeah,
anxiety, and it can unlearn. It can learn
yeah.
fatigue or brain fog or dizziness or tinnitus, and it can
Mhm.
unlearn those things. And that's why we're using. And then this overall treatment we're talking about now, we're talking about a term, neuroplastic recovery therapies.
Okay, I
Right.
like that.
So it's
Mhm.
neuroplastic recovery therapy, and that includes understanding. It includes the evaluation, making sure there's no structural condition. It
Mhm.
includes education about how the brain works, how the brain can and often does create real symptoms in the absence of structural damage. It includes the therapy, pain reprocessing therapy, and we've got good research on that, and it includes
Yep.
emotional awareness and expression therapy, which we also have good research on, showing that both of those are effective and more effective than standard psychological treatments for chronic pain. And it includes, finally, how we treat ourselves, how people
Mhm.
treat themselves. Do they care for themselves? Are they kind to themselves? Or how critical are they of themselves? How much do they assert their needs or stand up for themselves, or stop this over guilting themselves, or over
Over guilting.
perfectionizing, if that's
Yeah,
a word, themselves. And so that's the motto, those 5 steps, and
I
it's
really
all
like all that.
included in
Mhm.
that. Yeah.
Because, that last part that you mentioned, like, how you feel about yourself, you know, that is huge.
Yeah.
It's really huge how people view themselves, because that can also change their motivation, right, for making some of these changes, doing the practices that are going to support,
Yeah,
releasing the pain.
yeah,
Um, I'd like to circle back to, like, how do we diagnose this neuroplastic pain
right,
versus pain that's from a structural cause? Because a lot of people will say, "Well, no, I've had the MRI, I've got a bulging disc, or I've got,
right,
a rotator cuff tear, or
right,
these types of things, or I've been diagnosed with an autoimmune disease, like I was."
right, exactly. So we want to keep an open mind. We don't want to
Hmm.
just assume one way or the other before
Yeah.
delving into the data and looking at it carefully and closely. That's number one. Now, the next step is the structural side. We look for a structural problem. If someone has a cancer, an infection, a fracture, those are structural conditions that need to be treated first. Um, But we don't want to overinterpret a structural problem being there if the X-rays or MRIs show something that is also seen in healthy people without pain. And so the research shows very clearly that many people, as they age, have degenerative disc disease of the back without pain, have bulging discs without pain, have annular tears, spondylolisthesis, a variety of mild MRI abnormalities without pain. It's the same with knees and shoulders and hips. There are very good research showing that many people have labral tears, osteoarthritis, uh, other impingement syndromes on X-ray or MRI without pain. So when someone has those conditions on imaging, we shouldn't assume that that's the cause of the pain. We need to keep an open mind and investigate. farther. How do we investigate farther? Well, we use what I have developed and called the FIT criteria, FIT, functional, inconsistent, and triggered. So we look for the symptoms. Are the symptoms in a very wide area of the body? Well, that's a functional issue. Was it precipitated in the middle of the night without any injury? Is it bilateral on both sides of the body? Inconsistent. Does it come and go, turn on and off? Does it move around? Is it spreading? Is it triggered by the weather or by sound or light or smells or foods? And so we're looking for all these clues, just like I was talking about with the guy with the pharmacy when he walked in the pharmacy. That was his clue.
Mhm.
And that's what we're doing. So when we put it all together, and I've been doing this for 22 years, 23 years, whatever, almost 23 years. And it's not that hard. It's really not that hard. And that's what I write about in my books. I lay out all the criteria so that and usually people can figure it out for themselves reasonably well.
Mhm.
So that's how we do the assessment.